All right, great. I think we should start because this is technically a very lengthy course, which we have tried to squeeze in 1 hour or 1 hour, 20 minutes, something like that. I'm afraid it's a Zoom lecture, and historically it has always been very interactive and very physical. And our friend, Dr. Turki bin Dakhil, who has probably done most of these slides here. I mean, me and him, we used to do it together. So hopefully, inshallah, next year, Corona permitting and God permitting, we will do it physical, and Dr. Turki will be around here as well. So as the title suggests, this is about how to read a pentacam. So the aim of this course is just to clear the concepts and for you guys to understand that these are mere numbers. You don't need to know the numbers exactly because numbers come from different studies. So 47.2 or 30 microns or 20 micron doesn't actually mean anything unless there's a whole picture of a patient. Okay, so nobody will fail you, or you will not be in trouble if you say, oh, I'm not sure whether this is 10 micron or 15 micron. Certainly, I mean, if you say 54 diopter is not keratoconus and 32 is keratoconus, then you will be in trouble. But if you say 48 is not keratoconus or 45 is keratoconus, there is no issue with that. So this talk is mainly based on Pentacam, which is a tomography, which is elevation-based corneal mapping, and it uses two cameras. Technically, it uses one camera. One camera is for the fixation, and other is the shimfling camera, which takes about 25 cross sections of the cornea. And nowadays, it uses 2,760 points, and the rest of the data which it makes, which is 138,000, this is sort of an assumed data. So again, it's not a hard and fast sort of a written in stone, this data, okay? And that's why it varies from machine to machine. It varies from even one pentacam to another pentacam. So you have to take everything with a pinch of salt and make sure that you do more than one test. And there are a lot of different machines available which can use the shimflic image. Pentacam is the most commonly used one. The other good ones are Galili and Sirius, and obviously TMS5 and Opscan can also do these sort of things. And we all know very well that we cannot, these tools are not interchangeable. Like you cannot compare Pentacam versus Galili or versus Opscan. Certainly not Opscan at all. Just few basic principles. So when we are talking about any displacement, plus is on the right side and minus is on the left. Plus on the y-axis, plus is superior and minus is inferior. This is regardless of the laterality of the eye. And same goes with the degrees. So 0 is always on the right and 180 on the left. So irrespective of whether you're talking about the right eye and left eye, when we talk about 45, it will be supratemporal in the left eye and supranasal in the right eye. So we'll just go over the basics about the different powers, corneal powers, which we use, and then we will go into what is the best. So basic principles first. The sagittal power is the power which we all talk about, which is there in front of us, this one, and which everyone looks at when this JPEG image is on our computer. So sagittal power is just the corneal power, which is calculated using a refractive index of 1.3375, and it only considers the anterior surface. So this is more or less same, not exactly the same, which we use it for different IOL power calculation devices like IOL Master. But we all know very well, and people, your senior must have told you that you cannot use the sagittal power in IOL Master. Because the only difference is when we use Pentacam, we have to use simulated K readings, which are slightly different from sagittal power. Okay. So what is the difference between sagittal power and SIM-K? So if you go on the tab of pre-op cataract, it comes here on the tab, and then here you see the SIM-Ks. These are simulated Ks. They are not much different from the sagittal, except that it is based at 3 millimeter. Okay, so because Pentacam is doing the readings all over, depending upon like 8 millimeter to 0 here in the center, but IOL Master takes the reading at only 3 millimeter. Okay, so you take the sagittal case at 3 millimeter from the anterior surface only, using a refractive index of 1.3375, then this simulated case are equal to the IOL master case, and you can use it in IOL power calculation. So obviously simulated case or sagittal case are not the true power of the cornea. The true power of the cornea is basically the power of the cornea based on the two refractive indices. One in front, okay, so air has got a refractive index of 1, then the anterior surface 1.376, then there's a posterior surface, and then there is an aqueous humor with a refractive index of 1.336. Okay, altogether taking the sagittal curvature, how curved is the cornea, how much is the power at the anterior and the posterior, it does the calculation and it gives you a true net power. Okay, so this is the true net power of the cornea at a particular point. Okay, so here it says it is 48, here it is giving you 50, so the true net power is actually less than certainly in this case. Now if you have got a sort of a refractive surgery done, you want to use a true net power, you cannot use true net power in the IOL calculations, because true net power does not use the assumption of 1.3375, which is used by IOL master. So you cannot put true net power if a patient has got a scar or irregular cornea or a previous LASIK, anything. So you cannot use true net power, although it is true, but it is not following the assumption that the refractive index of the cornea is 1.3375. So what do? You use equivalent K reading. So you go on the tab to the holiday report, and it generates this equivalent K readings at 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, 5 millimeter. So what it does, it basically calculates the true net power of the cornea. Okay, and then it uses the same assumption that the refractive index of the cornea is 1.3375, which technically means that the posterior cornea is 82% more curved compared to the anterior cornea. Okay, so it's a bit confusing. So what you want to remember here is that equivalent K, you can use equivalent K, and equivalent case uses true net power, then it uses the assumption. So it calculates the posterior curvature, then it changes the anterior curvature based on the refractive index of 1.3375, and then you can use it. So in other words, AKR map is corrected by adding the error that was created because of the use of 1.3375, because we have made a historical error 100 years ago that the refractive index is 1.3375. So to correct this error, we have to do all these sort of assumptions. So what is the actual power of the cornea? So even true net power is not the power of the cornea. So the actual power of which is known as total corneal refractive power. This is calculated by Pentacam as well using a ray tracing. So previously it was a Snell method. Okay, so this is a ray tracing, because you see an object here when it is standing, an object here. The ray passes here is different from the ray which is passing from there. So they will fall on a different angle. So this is based on a fixation point, and the rays go in. So once the ray goes into the cornea, there is even a tiny sort of an angle here, okay, which the Snellen law does not say. Then when it comes here, there is a tiny angle here, okay. And similarly, the one which refract, so let us use this a bigger image. The one which are going from the center are going straight. The more peripheral they go, they have to bend more. So true corneal refractive power includes everything, like true net power, including the location of the object, including the slope of the surface, including the internal reflection of the light, including the anterior and the posterior surface. So in actual fact, it is true net power in plus including the spherical abrasion, which are induced as the cornea goes more peripheral. And this is the actual true corneal refractive power. And many of these new IOL calculation devices for previous LASIK, they want you to have this total corneal refractive power. Now, when you are looking for a refractive maps, there is a tangential map, there is a sagittal or axial map, and there is a refractive power map, okay? So refractive power map, I mean, I just want to tell you because you must not be using it, and certainly at this level. But in this one, as it goes to the periphery, the power of the cornea increases. So this is based on the same ray tracing formula and using a point relative to the fovea. So anything here will be refracting more. So the power of the cornea for a thing here is more here compared to here, So the refractive power map, as we go from the center to the periphery, the refraction or the dioptric power or the radius, the dioptric power of the cornea increases. Okay, this is just to add your confusion, but just ignore this now or forever. So we talk about the reference surfaces. I mean, we talk about what is a best fit sphere or what is a best fit toric ellipsoid. So sphere, we all know it is a sphere, okay? What is toric ellipsoid? Okay, toric ellipsoid is actually a more sort of a, what do you call it, resembles the eye. Eye is ellipsoid, which means it's not round. Okay, so the horizontally, the eye has got more white to white compared to vertical. So it is ellipsoid. And then because it is ellipsoid, because there is upper lid, lower lid, it is toric as well. So most of us, when we are born, we have got with the rule astigmatism. So an ideal cornea is a toric, not ideal cornea. So a cornea is a toric ellipsoid. So an ideal fit or a reference surface should be a toric ellipsoid. Okay. So when to use the best sphere width, most of the time you should use best sphere width because it tells you where exactly what is the shape of the cornea or where exactly the location is. So if you're doing refractive surgery or you want to screen patients for post-LASIK ectasia, best sphere fit is good for you. But if you are dealing with keratoconus patient and you want to see what's happening, you want to put the rings and you want to see how much is the cone there and how high is the cone, like how much posterior elevation is there, then you use toric ellipsoid. So toric ellipsoid is good because it tells the details of the shape of the cornea, that is height of the cone. Okay, so the height of the cone is increasing. You see one day the posterior elevation is 36 and you see next year it is 48. So you will get better idea if you're using a toric ellipsoid compared to a sphere. So what exactly is this sphere fit or toric ellipsoid? It's basically, it's a reference shape, okay? And it's based on the average keratometric value over the cornea, okay? So this is, let's suppose this is the cornea of the patient, okay? So this is the reference point the Pentacam will create based on the different keratometric values at different points. Okay, so this, it will depress in here, this, it will move it up till it gets an average reference point or best sphere fit. So for every cornea, the best sphere fit will be different based on the particular case and particular asphericity and particular irregularity. Okay, so anything, so best sphere fit is not used for sagittal maps, it's not used for pecumetry, it's used for the elevation. Okay, so posterior and the elevation and posterior and anterior elevation. So anything above the sphere fit is elevated. Okay, and it is in plus, and it means there is thinning or ectasia or cone. And we know very well is to locate a cone, again, as we know that we have to use the elevation map, the posterior elevation, not the curvature map, tell exactly where the cone is. And then we correlate it with the pecumetry map. And this is something which we all know very well, but I just want to recap that if you change the best sphere fit diameter, okay, so I'm not talking about the best sphere fit value. Whatever value is coming, it will come from the patient eye. But you can decide whether you want to take an 8 millimeter, 10 millimeter, 12 millimeter, and 6 millimeter. We usually take 8 millimeter because this is where most of the data comes from. Okay, but if you are using 12 millimeter of the optical zone to calculate the best sphere fit, the peripheral cornea is flat. So when we calculate a best sphere fit for a 12 millimeter, the best sphere fit, which was for 8 was 45, will become 40 because it is including a peripheral flatter cornea. Similarly, if we decrease the size of the optical zone, the best sphere fit from the center will, because there's a steeper cornea, it will be 50, which means that if you go for a larger optical zone to calculate the best sphere fit, you will overdiagnose keratoconus. And if you are using a smaller optical zone for best sphere fit, you will underdiagnose. So hence 8 millimeter is taken as standard. So this is a good example. So here you can see a posterior elevation is 20 with 7.5, which increases to 26 when we go to 8.5 millimeter. So there are three types of data which we usually gather from the Pentacam: tomographic data, topometric data, and pecumetric data. We'll see how much we can cover this in detail, but the most common one is the tomographic data, the 4 refractive maps we call it. So this is what we usually see in the JPEG picture in our computer, or if you go to the Pentacam machine. Okay, and first of all, you have to check the patient eye, left, right, alignment, and stuff like that. So here, good thing is, look, say that the quality is okay, okay? But to me, it doesn't look okay because I see a lot of dots here, okay? So, and the pupil is not roundish. So what is happening here? What is happening here is the patient is looking to the left side or temporally, okay? So the hint is oval pupil, okay? That the pupil is not roundish because it is just taking a photo. And then you see a lot of extruded data on this side, depending on which side the patient is looking. So the same patient, when he's looking straight, look, the indices changed compared to this to this. So make sure not only it says okay, the pupil is round, provided the pupil is round, and it is symmetrical all around. So as I said, these dots mean that there is extrapolated data, which means there was no data available, and the computer just assumed this data. And usually it happens if there are peripheral opacities, you have dryness, you have arcus senilis, there's too much reflection from the pterygium or something, like pterygium not on the cornea, like pincula or something, and you got too much reflection there, and the computer just cannot take a good image, and it just sort of computes the data there. So this is the patient details information box, which eye we're talking about, date of birth, and the date of the examination, very important. And this is where we look at usually about K1, K2, Kmax, pecumetry, and the deviation. So again, going back to the axial and sagittal map. So it is a sagittal map which is there, okay? We don't use normally tangential map, although it is more accurate, okay? And we'll just talk, I think, in the next couple of slides. And it is less sensitive to the eye alignment, okay? But there's too much data and too much noise, and it doesn't look very, very good, not very appeasing to the eye. So you have an option to decide which curvature map you want. You can have axial map, you can have tangential map, you can have a true net power, you can have a keratometric power deviation, you can have a refractive power, and you can have even EKR here. So this is axial versus tangential. What's the difference? So, I mean, this is very important as a basic rule to know, okay? So axial map, which we usually use, is basically created by the radius of curvature at this point with a reference to this fixation point, okay? So the radius of curvature is this, okay? So this is the radius of curvature at this point. This is the radius of curvature at this point, and the radius of curvature has increased slightly here at this point. So as the radius of curvature increases, the diopter decreases. So, okay, in between, the radius of curvature will be something in between the two. So as there is a horizontal line, the axial to the corneal surface, and we draw a normal or a perpendicular to the fixation, and whatever the radius is, that is the radius of curvature, which increases. In other way, cornea flattens as we go peripheral. Okay, this is how you calculate the sagittal axis. The way you calculate the tangential, not sagittal axis, sagittal power or axial power. The way you calculate a tangential power or curvature map is just like, imagine you have got a big cornea in your hand, okay? And then you use tiny balls or tiny spheres to fit in, okay? So at any particular point, you put a tiny ball there, a sphere there, and then you see whether this sphere matches with the sphere of the cornea. You say, okay, you put a 48 radius of curvature, it fits 48. So you said it is 48. It goes there, it is 39. So radius of curvature is high or the adapter is low. So basically what the computer is doing, it is putting multiple spheres, and whatever sphere fits well on the surface of the cornea, it calls that diopter or curvature or the yes, like diopter or radius of. So which means that this is more accurate. In general, the axial maps, they try to normalize the things, okay? So the steep curvatures will become flat, and the flat curvatures become a bit steep. So it takes it more towards sort of a normality. So it helps in viewing, and you will see in the next slide. And most of the detail you get it are from the center, okay? Because as you go to the peripheral, this becomes less accurate, okay? So it's not good for the peripheral details. On the other hand, tangential maps, they offer a true picture, okay? And they move the things toward the center, okay? So actually they don't move the things toward the center, like there's too much data, and you can get the peripheral images much better. So you can use it for peripheral pathologies or the pathologies I'm going to talk about in a second. So, but there is too much details. There are too much details, okay? So K readings, it will go lower value, it will give you higher value, which is probably more true, okay? So the cone location, it will move the cone towards the center, okay? It is sensitivity to the curvature changes. It is very high, so it's more sensitive. You will get a better curvature, okay? But the problem is, if you have got tear film abnormalities or a bit of a scar, there is sensitivity is higher, okay? So it can, it may not be very accurate. But on the other hand, if the patient is moving, not aligned properly, it will give you a better reading. So in summary, if you have got a peripheral ectasia, PMD, if you have got eccentric grafts, if the patient visual fixation is not very good, if the fixation is not very central or large angle kappa, these sort of things, then these tangential maps are better. And this is the same patient, okay? So same patient, looks like too much pathology there, isn't it? So this is the steep area, which is 52.3, well, 53.5, like this, and it has become more steeper here, so 57.2. The other thing is, it has moved slightly more towards the center, okay? So in summary, as I said in the back page, it is used for poor visual fixation, eccentric fixation, angle kappa is large, eccentric graft, and pellucid marginal degeneration. Otherwise, don't use these tangential maps. Okay, so this was about map. Then this is about the pecumetry map, which is there, which tells you about the thickness. And this, the top right, is the front elevation or anterior float, we call it. And this is the bottom right is the back elevation or the posterior float, we call it. So when it comes to the data, so it gives you a front corneal curvature, it gives you a back corneal curvature, and it tells you about the quality and the sphericity. So the quality, I mean, Pentacam is idiot-proof nowadays. So anything white is normal, anything yellow is suspicious, anything red, do not attempt or repeat. Q value, what is the Q value? Q value is the asphericity of the cornea. So the cornea is not sphere, it is prolate. It is slightly more sort of steep in the center, and in the periphery it goes flatter. So normal value range from minus 0.26 to 0.42. It could be anything even a little longer, but some people say from even to -1 it is normal. But the ideal or Q value, or the what you call it, the best Q value is 0.027. Okay, and this is how it is. So Q value is 0 if something is a sphere. As it goes steeper in the center and flatter in the periphery, like cornea, it's prolate. So Q value starts to go towards the minus. And if it is an oblate, where it is flatter in the center and steeper in the periphery, like after post-LASIK correction, it becomes oblate and it goes towards plus. And if it is really keratoconic, we call it hyperprolate, and it is usually more than -1. So again, this is not a hard or fast rule, but normal is usually less than 0.5. Anything more than 0.5 to 0.55 or 11.6 is normal. Anything more than that is suspicious. Again, abnormal, but alone it does not mean anything. So how this is basically the radius of curvature at horizontal. This is radius of curvature at vertical meridian. And this corresponds to the dioptric power in diopters, K1, which is the flattest K. And flattest Ks are important. They're important because when you're doing a LASIK myopic correction, we don't want to go more than 34 diopters flattening effect, because then the quality of the vision will be effective. In general, each one diopter treatment of myopia causes a flattening of about 0.75 diopters. K2 is in red, which is a steeper central K reading at 3 millimeter. And this is important that it must not go more than 48 in case we are treating a hyperopic patient. And each one diopter treatment of hyperopia will steepen a cornea or K2 by 1 to 1.2 diopters. K mean is the average between K1 and K2. And obviously, and that tells you about the astigmatism. Astigmatism is again the difference between K1 and K2. We don't have much time, but I'll just go for the, like, you have to calculate not only the astigmatism of the cornea, but the lenticular astigmatism, anterior surface astigmatism, and the posterior surface of the corneal astigmatism. Usually the anterior astigmatism of the anterior corneal surface is with the rule, but with age, it becomes against the rule. Whereas the posterior corneal surface is with the rule and it does not change with aging. And this is very important once we are doing the toric IOLs, and now we keep in consideration, and many of the toric IOL calculators, they already use the assumption which I just showed. So you have to compare the astigmatism of the cornea with the cylinder in the manifest refraction. Okay, and you should make sure that they are within, like, they align with each other. Ideally, if any astigmatism is more than 1.1 or 1.5, and the difference is more than 15 degrees, then there is an element of irregular astigmatism. So this is when you're doing topo-guided treatments like Contura, or whether you have to decide whether you want to do treatment based on the cylinder or you want to do based on the astigmatism of the cornea. You have to make sure that this aligns with each other. Otherwise, there is an element of irregular astigmatism. So with the rule astigmatism, we all know very well, steep on this direction. And this is the axis which tells, so you can change the axis to flat, or you can change it to steep, and then it says what is the axis. So if the astigmatism is oblique, I'm not talking about if it is not oblique. It's normal usually, anything less than 2. again, these are not hard and fast rule, but certainly if it is more than 6 diopter, it is very abnormal. Okay. And we talked about this. So again, this RPR is basically the radius of curvature at 7 to 9 millimeter or 8 millimeter ring area. And this is the minimal radius of curvature at 7.77 in this case. The back cornea, again, it has got K1 and K2, and it is in the minus because the back cornea becomes more like a concave lens because it is present in the aqueous, and the way it is sitting there, obviously, compared to the air versus the anterior surface, which is convex, the posterior cornea versus the aqueous is concave, and that's why it is in minus. So it is minus 5.9 diopter, K1, the steepest is 6.1, and they are again in minus. And then it also again tells you about the axis, which more or less corresponds with the anterior sort of a surface, meaning probably this patient is a youngish patient. And after the keratometry readings, the next sort of a box is about the pecumetry. And these signs shows this is the center of the pupil, this is the center of the or apex of the cornea, and this is the thinnest location. Okay, and this diamond shape means maximum keratometry. Okay, so now we'll come to the same points, which was X is always towards the right. Sorry, plus is always to the right in X, and Y plus always mean it has moved superiorly, and if it is minus, it means it has moved inferiorly. Okay. So pecumetry at the pupil center is 493 micron. Okay, but what is this? 0.16 or minus 0.1. This is the center of the pupil, how much it has shifted from the visual axis. So it is an indirect way of calculating the angle kappa. The Pentacam doesn't have Placido, so it cannot calculate the angle. Okay, so it uses a formula, and it calculates the mu chord, and it calculates the angle kappa based on the formula. So any deviation or any angle kappa less than 0.2 is normal. I mean, it doesn't mean normal. Normal means that this is a normal sort of a placed pupil versus a visual axis. When we call suspicious, we are talking about I mean, doesn't mean that there is anything wrong when people have more than that, but you have to be very careful when you are planning to do refractive surgery or putting multifocal IOLs. It's certainly the refractive ones. Okay, so it doesn't mean it's abnormal. It just means that you have to be careful deciding about the refractive surgery and the multifocal IOLs, and in hyperopic patients using toric IOLs as well. Then obviously you have to compare. I mean, this is something you don't need to know. So back here at the apex. So this is tell you the apex of the cornea, the thickness is 496. And the reason it is 0 and 0 because this is taken as a reference point. Okay, so this will always be 0. So the thinnest location, and this is important. Okay, so this tells you what is the thinnest location and how much it has deviated. So normal is taken as less than 500 micron. Okay, so this is 0.85 towards the right side and 0.6 inferiorly. Okay, so this is suspicious, isn't it? So thinnest location, let's talk about the thickness first. It says that 500 micron is normal, anything less than 500 and 470 is suspicious, less than 470 or 460 is taken as suspicious of FI, like petaconic. So you have to compare between the two eyes, the thinnest thinnest pecumetry. The difference should not be more than 10 to 20 microns. Anything more than 25 to 30 suspicious. Anything more than 35, the thinnest cornea in both eyes is taken as abnormal. And similarly, the difference between the apex and the thinnest location should not be more than 10 micron. If it is more than 10 micron, it is abnormal. And this is the deviation I was about to say. Anything less than 0.5 is normal, 0.5 to 1 is suspicious, and more than 1 millimeter is abnormal. So when you come to the Kmax again, normal is 47.2. In some papers, it is 48. Suspicious between 47.2 to 50, and abnormal more than 50. Again, when you take 50, this is where the specificity and sensitivity sort of match each other. But certainly, if you increase this 50 to 54, it will become more sensitive. So ideally, the difference between the Kmax between the both eyes should not be more than 1.9 diopters. And the difference between the Kmax and the K2 in the center should be 1 diopter or less. Anything more than 1 diopter is suspicious. Again, it is suspicious. It does not mean that there is a keratoconus or you must not do refractive surgery. Then there is an angle there as well, which is used for patient for glaucoma or when you're planning to do an ICL and stuff like that. But this is the keratometric power difference, which again has the difference between the two net power and the sagittal curvature. So if a patient who has got a LASIK done or patient who has got a keratoconus, this number will certainly be high. We don't use it. Usually we have white to white here, but any KPD value of more than 1.5 is abnormal. Anterior chamber depth is important. Anterior chamber depth can be measured internally or externally. Externally means that it takes from the epithelium of the cornea, and internally means it is from the endothelium. This is important for the AC depth in cases of you're planning to do a phakic surgery, phakic IOLs, or any other thing. So pupillary diameter, it comes, people used to say that this sort of calculates a scotopic pupil, but because there's a blue light and there's a fixation light, it is sort of more in between mesopic and scotopic. So I prefer using OCTs or TOMI, which uses infrared red light, and that gives you a better mesopic pupil diameter. And IOP adjustment, you can be done based on the thickness of the cornea, and the lens thickness, you can measure the lens thickness when the pupil is sufficiently dilated. And white to white, it just says how the wide of cornea is at the horizontal level. So this is horizontal white to white. Vertical white to white is difficult. It's not difficult, but because there is a lid, so by convention, it takes the horizontal white to white. And you need this to decide about ICL size, about IOL size, CTR sizes, and anything when you're dealing with sulcus. Left eye, we have to look. T means temporal, we know very well, and means normal, and this tells you about the diameter, how much of the cornea is being computed, and it could be 8 or it could be 12 or it could be anything in between. So you need a bigger sort of or larger diameter assessment for if you are looking for pellucid marginal degeneration. So this is a same patient. This is 8 millimeter scan, and this is a 12 millimeter scan, which you can see that things have not changed much, but you can see what happens with if you're going with a bigger one, then certainly you will end up with some sort of extrapolated data. So ideally we don't use it. That's why we only use it 8 millimeter. But if we are looking for pellucid, we have to go for a larger diameter size. And this is a good example that this is which we did an 8, and this is 8, and this is 12. Yeah. So here you cannot see that cone or elevation. Look here, you're seeing 45. It may be somewhere there, and suddenly, hooray! Here we go. We got 52.1. So it's the same sagittal curvature. The only thing is we have increased the diameter of the assessment. And the color, it says, so don't get confused with the colors. Colors don't mean anything. So this is the same sort of curvatures, but different machines have got a different colors adjustment. So color don't mean anything. So let's talk about the keratometry readings. We said that Kmax, anything more than 47.2 is abnormal. So not only Kmax is important, it's also important where do these keratometry readings sit, which is we are talking about the irregularity or asymmetry. The one thing is inferior superior asymmetry. So ideally there should be less than 1.2 asymmetry between the keratometries at 3 to 5 millimeter, 5 millimeter superior to inferior. Anything more than 1.2 is suspicious. Anything more than 1.5 can be abnormal. And the other thing is the skewed, sorry. And the other thing is the skewed radial axis, that what is the angle which is being made at the two corresponding steep points, and I'll come to that. So inferior superior asymmetry, normal less than 1.2, suspicious between 1.2 to 1.5, anything more than 1.5 is abnormal between the two opposing points at 5 millimeter circle. But when we consider superior inferior asymmetry, because keratoconus is usually inferior, we have more margin of error, and here 2.5 is taken as abnormal. So this is skewed radial axis value you're talking about. So this is the angle we are talking about. So everybody agrees that this is quite skewed towards the right side. Ideally, a bow tie, asymmetrical or symmetrical, should be like this, but this is skewed towards the right side in this case. So how much is normal and how much is abnormal? So this is how you create an angle between this axis and this axis, and this axis, this angle seems to be very high. And if it is 21 or less than 21, it is taken as normal. If it is more than 20, it is 22 or more, it is abnormal, provided the astigmatism is more than 1 or 1.5. Anything less than 1, even if it is 22, 23, it does not make much difference. So this is what we are talking about here. So 48 here and 51 there. So we create this angle and this angle, and this angle seems to be sort of more than 20, 21. Yeah, it's almost 30. So this is abnormal. And these are the different patterns which can be normal or abnormal: a round astigmatism, oval, symmetrical bow tie, asymmetrical bow tie. So there is more inferior steepening, more superior steepening, irregular astigmatism, skewed, and butterfly, crab claw, junctional, kissing. So these are suspicious. This is not suspicious. This may not be suspicious. So very important things, that not only you have to look at the keratometry readings, you have to look at the patterns. Okay, so butterfly, claw, junctional, inferiorly, they are the patterns which you have to look for. Asymmetrical bow ties. Okay, and there are different formulas to calculate. You don't need to know that at this stage. So in summary, K max not more than 47.2, skew axis less than 21, inferior superior symmetry less than 1.5, superior inferior asymmetry less than 2.5, and corneal astigmatism less than 6 may be normal. If it is against the rule, and if it is beyond these readings, then it is abnormal. Now we come to the corneal thickness. So not only we are talking about how thin is the cornea, the location is even more important than the thinning itself. So this central dot tells you about where the pupil is, and this tells you this empty dot, empty sort of a circle, that the exact location of the thinnest cornea. So this is the center of the pupil with the plus, and this tells you the deviation. And if you look here, it tells you very well the thinnest location is 0.85, so which is suspicious, isn't it? Vertically as well as horizontally. So it is deviated right, okay, and deviated inferiorly. So not only this is important, then another thing important is what is the difference of pecumetries between inferior and superior at 5 millimeter. Okay, anything less than 30 micron is normal. Anything more than 30 micron is suspicious. Other thing is about the shape of this thinning, then that tells you a lot. Is it a dome shape, or is it, excuse me, sorry. Is it a dome shape or is it a bell shape? What sort of these cone asymmetry thinnings are? As we all know, that bell shape is a hallmark of pellucid marginal degeneration with inferior thinning. So thinnest location more than so less than 470 micron. Displacement of thinnest location by more than 500 micron from the center. Difference between both eyes of more than 30 micron. Difference of more than 30 micron between inferior and superior. And a cone-like pattern or a bell-shape-like pattern means it is suspicious. Now we'll talk about the elevations, anterior and the posterior elevations. We will talk about, and we use best sphere fit here. So cone appears more obvious with the best sphere fit than best fit toric ellipsoid. It's just because sphere fit is not the ideal shape of the cornea. That's why you can see the cone better, but you cannot read about the height of the cone, but you can see, so you can locate the cone better. And this is the diameter we were talking about. You should do it a manual, and you should keep it same whenever you are doing it repeat calculations. I mean, every now and then we have a problem. We see a patient and we think, oh, the patient has progressed. And then we find out that the best sphere fit diameter has been increased from 8 to 9 or 9 to 10. And this is exactly what happens. And we showed it before that from 7.5 millimeter diameter of best sphere fit, it was 20. And if you use 8.5, it becomes 26. So 20, you may take it as sort of a normalish, but 26 is certainly not. So elevations are, so the back elevations also tells you about the exact location of the cone. And this location of the cone is, you have to correspond it with the thinnest location, but not with the sagittal map. And this tells you where exactly the cone is, and then you can decide how and where to put the intacs, certainly. And you grade the cone based on the posterior elevation. So the central cones are which are within the 3 millimeter of the center of the cornea, paracentral, which are between 3 to 5 millimeter, and the peripheral cones, which are outside the 5 millimeter zone. So tongue-like protrusions are very suspicious. And again, the shape and the is it isolated or is it not isolated? And this is a sort of a normal elevation map you see. So hourglass usually means normal. And this just tells you about, you don't need to know about how the astigmatism is calculated, but this is elevation. So this is, the colors are different compared to, so the here it is blue, okay? So it is still steep, but it is blue, okay? So the back elevation, okay? So elevation, again, we are using most of the time the best sphere fit, okay? So if you're using toric ellipsoid is more sensitive, so that's why we need lower numbers. But for best sphere fit, for the back elevations, okay, anything less than 17 is fine. Anything between 18 to 20 is suspicious. Anything more than 20 micron is abnormal. And this is for best sphere fit. For best sphere toric ellipsoid, the number goes less, and usually it is taken as 15. No, less than 15 is normal. Yeah, so anything less than 12 is totally normal. Between 13 to 15 is suspicious for best sphere fit. For best fit toric ellipsoid, and anything more than 15 is abnormal. Because we are using usually the best sphere fit, so if someone needs to remember these numbers, then just stick with these numbers, and just keep in mind that for best fit toric ellipsoid, the numbers are even less because it is more accurate. So this was topographic data or tomographic data. Now we'll go to topometric. Topometric is how much or irregularity is there. Okay, so topo is basically the topography. Okay, so elevations and depression, and metric is the measurements. I don't know how much time we have got, but we'll continue till at least 4:15 or 4:20. Okay, and topometric data, there are different equations and different formulas are there just to quantify. So topometric data is quantification of keratoconus or ectasia. So there is a KPI, not our hospital KPIs, but the different KPIs, keratoconus prediction index. Then there is a KISS I will talk about. Then there's a central keratoconus index. Then there is CLMI. This is slightly more advanced. It's probably not for the residents and even not for the fellows, but just in case you want to know. So you go to the tab of topometric analysis, and it comes up with this sort of a picture. And these are the indices which are used to calculate these different KPI, KISA, KI, or CLMI. And the indices used are ISV, IHA, IVA, IHD, so surface variance, vertical asymmetry, height decentration, height asymmetry. And then you use all these sort of indices to calculate and tell whether there's a keratoconus or not. Here it says the keratoconus grade is between 2 to 3. And the central keratoconus index is 1.1. The thing is, Pentacam is idiot proof, and anything red, we all know that it is abnormal, anything yellow is suspicious. So again, you don't need to remember these numbers, and just remember that the colors, okay? So index of service, I'm not going into the details about, but what it talks about, how much irregular astigmatism is there. Index of vertical asymmetry means that how much it is asymmetrical between superior and inferior. So same thing, like we're talking about the K reasons, inferior superior asymmetry. So height asymmetry is again the same thing. This is based on the elevations, okay? And the height decentration, they're talking about how much decentered the thickness is. So you use all these sort of indices, and then you calculate the different index, okay? One is KISA, one is KPI, one is CKI, one is KI, okay? Vertical asymmetry is probably the most sensitive among all of these. And these are the different readings. If someone wants to remember them by heart, by all means, they can remember it. And then you use a KISA index, which is there in the Pentacam as well, and it gives you percentage based on keratometry at the center, inferior superior asymmetry, the skewed radial axis, and the magnitude of the astigmatism, and it gives you a percentage. Less than 60% is normal, between 60 to 100% is abnormal, suspicious, and anything more than 100 is abnormal. Now, recently they have added the new staging of keratoconus, which is A, B, C, D staging. And it comes in when you go for topometric keratoconus staging, it will come there. And it tells you what is the stage of keratoconus based on the new grading of the keratoconus, which is there's a consensus to use this grading. And A means basically anterior radius of curvature. PRC is the posterior radius of curvature, thinnest pecumetry, and the best corrected distant visual acuity. So as long as you know all these data, it fits in. In the left eye, it is A is 0, B is 0, 0 means normal, C 1 slightly suspicious, and D is empty because they haven't put the visual acuity in this patient. Goes to the right eye, you can see A is 2, B is 2, C is 2, D is not there because they didn't put the vision, but altogether it looks like a keratoconus. So it quantifies keratoconus like Emsler, Krumach is sort of a classification, but this is more sort of objective, more objective, and this is now we use most of the time. And again, there it says there's a keratoconus, okay? And these are the values. I mean, this is something good, which I think if someone wants to remember this is important. So anything less than 46.5 is normal, more than 48 is stage 1, 48 to 53 stage 2, 53 to 55 stage 3, and more than 55 is stage 4. So anybody doing research in keratoconus nowadays have to use these sort of K readings, and again, the pecumetry as it goes down, it decreases. More than 490 is totally normal, between 490 to 450 is stage 1, and then it goes down. So bad or Bellin-Ambrosi enhanced ectasia display was sort of created just to screen and to make sure that they're not missing any false negative. So the criteria they just changed the best fit in a way, so they can make the criteria more stringent. In a way, the screening becomes more sensitive. So basically, you don't lose any false negative. Hence, you decrease the risk of post-LASIK ectasia. And how do they do that? Basically, it's very simple. So we all know that the peripheral cornea is flat and central cornea is steep, okay? So if you use all of the cornea at 12 millimeter, it will become flattish, isn't it? If you use less cornea, the best sphere fit will be low, okay? But there's another problem. This is a normal cornea, but the problem in keratoconus is something like this. So keratoconus may be normal there, and then there's a focal thinning or protrusion, okay? So because of this focal protrusion, the best sphere fit will be made from here, including 41, 42, 43, and 55. So when you include a best sphere fit, including 55, the best sphere fit will be artificially very high, okay? So here the best sphere fit is 45.2, okay? So if it is 45.2, then the elevation just is 9.75. So what they do, machine excludes this 3.5 diameter optical zone around the thinnest location, okay? So they remove the thinnest location or the protrusion, and they create a new best sphere fit. So obviously this best sphere fit is more flat, and when it is more flat, now the best sphere fits become 42 compared to slightly high before, okay? Now the apex is 13 diopter more elevated, okay? So now it is more enhanced, okay? So this is the principle behind it, that they remove the cone from the center to calculate the best sphere fit. Now anything which is above that is abnormal. So the aim of this is that the cone can easily be detected. So that's the aim. So this was before. You can see here, if you want to think, I mean, they're more or less they're the same curvature, but here they're using enhanced bad, and this is a standard best sphere fit. Here the difference is little, and here the difference is more. And this is how it is displayed. And this is the, and you can say it looks very red. So again, idiot proof, everything is idiot proof. But this is the enhanced elevation data. And this is the pecumetric distribution, okay? So again, it tells you about the front elevation and the back elevation. And as you will see down here, the numbers are now less compared to the numbers which were before, okay? So now before it was 20, more than 20 was suspicious. Now more than 16 will become suspicious because we have changed the best sphere fit. So for the back map, so this is front and this is back. Less than 12 is normal, between 12 to 16 is abnormal, and more than 16 is abnormal. So, but again, you don't need to remember this because here it tells you about what is normal and abnormal, and certainly we know that that red is abnormal. So this is the pecumetry progression index, okay? So this is again slightly sort of a complex, and it is based on Renato Ambrosio. He calculated his sort of a relational thickness, how the cornea gets thicker and thicker as it moves from the thinner point, okay? So, and so this is known as Ambrosio rational thickness. In general, the average, if it is less than 424 micron, or of the maximum is less than 339 micron, it is fine. Anything more than that is abnormal. Again, you don't need to remember it. And this probably is the most important map if you are doing a post-LASIK ectasia workup or your refractive surgery workup. But again, it will tell you if anything is in red, it will be suspicious, not suspicious, abnormal. And this is the spatial thickness, how the cornea gets thicker or thinner as it moves away from the thinnest point, okay? So it does two things. So one is the CTSP, corneal thickness spatial profile. So the thickness measures along as it moves away from the thinnest point, okay? So, and again, if you look at the graph itself, it tells you suddenly there is an abrupt change there. faster and abrupt increase. Okay, faster and abrupt increase of CTSP means there is something wrong. Okay, again, it's a bit too complex for you guys to know this, but as I keep telling you, keep this thing in mind that red is abnormal. Okay, so we talked about this and the readings are there, but again, you don't need to remember this. Apart from that, these are the progression index developed by Ronto embryos, just to tell that this is very sensitive. Actually, it's very sensitive, but you just keep in mind that anything red is suspicion here. Okay. So in PMD, you can see it is going up because the area of the thinning is not in the center, it goes towards the periphery. And again, Fuchs, it can happen the same thing. Okay. So the thickness starts as, so periphery, it could be thick. Okay. So it goes opposite. So then you see these indices down at the bottom of this thing. And again, if you see all white, you are fine. If you see 2 yellow or 1 yellow, it is suspicious. If you see 1 red, then don't do it. And these are basically the deviations from, so DF is from the front elevation or the anterior elevation, DB is the back elevation. And again, you don't need to remember this because it will become red, whatever the readings are. So deviation of the normal of the back cornea, again, it tells you, so this is the back elevation, this is the pecumetry progression, okay, this is the thinnest point deviation, okay, and this is the art, the ambrosio-rational thickness profile maximum, okay, and then it calculates the total deviation. So this is important. Anything less than 1.6 is normal, between 1.6 to 2.11 is suspicious, and anything more than 2.11 is abnormal. And this is probably the most sensitive index ever developed by Pentacam. So this is the most sensitive index. So you have to always compare that. You can also compare the 2 exams in Pentacam. How are we doing with the time? Already 4 o'clock. Okay. And then you can decide whether there is a progression or not. We have this available here, and if you can go to the Pentacam room, it can tell you. So this is the difference. So the corneal thickness has sort of my -12, slightly thin, -12. Okay, so between the 2 dates, so between 2nd of November and 6th of July. Okay, so not much difference between the 2. So similarly, you can look at the front elevation and back elevation, and you can see the difference is only 3 or 8. Okay, 8 is a bit suspicious here. 7, yeah. So it has gone from 31 to 39. And then it can use and it can plot and it can tell you whether the ABCD progression, so whether the keratoconus has progressed from like A0 to A1 or A1 to A2. So it says here in 2017, A to B to C2, and in 20 to 19, still A to B to C2. So this is a good way of checking progression and deciding about cross-linking and seeing whether the cross-linking is working or not. I wish we have this in our room and we can go through it rather than comparing 2 photos all the time. And hopefully in the near future, we will have this in our rooms. So holiday EKR report, we briefly touched before. I don't want to go in further details here. I just want you to show that this is how it looks like. It is calculated based on the center of the pupil, or it can be calculated based on the apex of the cornea, and you can use EKR. I only use it as a double check to make sure that how accurate our post-op IOL calculation will be if we are using whatever formula, Higgins L or ACRS website IOL calculators or any other Barrett or also stuff like that. So again, I don't think so you need to go into the details. So if I see something like this with a good peak, So this is basically a virgin eye. Okay, so this is how it looks like. So if it is post-refractive surgery, we don't have time to discuss why it is like this. Okay, but this is just the way. We can discuss later, or we can have a full talk on EKR. So if it is a tight peak, it means you are pretty sure, or your confidence increases, and you can tell exactly the patient that whatever IOL calculation or power is coming out, it aims to hit high. But if you see something like that, there is no clear peak, there is a good chance that you are not sure whether the IOL of 21 is good or 24, and you can end up with over or under correction. So if you see this, you should be happy. If you see this, just warn the patient. Also on the EKR report, there is a spherical aberration, sort of a tab there, tells you how much spherical aberrations are there. And this can help you to decide what lens you can use. A normal corneal spherical aberration is about 0.27. So this is something different from asphericity, totally, okay? Asphericity is the shape of the cornea, okay? And spherical aberration is how much the rays are reflected in the periphery compared to the center, okay? So these are the two different things, although the numbers are similar, like asphericity was also something like that, but it was in minus 0.27. But spherical aberration is an aberration, okay? This is like defocus, okay? So average corneal spherical aberration is 0.27. So this is a lot high. So this is quite aberrated cornea, okay? So IOL selection can be done based on spherical aberrations you have got. So you can use thickness lens if you have got spherical aberrations of plus 0.33, because this is the lens which has got the maximum minus 0.27. Or you can decide not to use any, or you can use a neutral aspherical lens if the patient's spherical aberrations are towards the 0 or less. So if the patient does not have any prior refractive surgery, and there's a risk of IOL decentration, okay? So always use a 0 spherical aberration lens, okay? So use an aspheric IOL, but with 0 spherical aberration, because if this IOL is decentered, you will induce coma and tilt, okay? So if the IOL is not likely to be decentered, so we are talking about a virgin eye, no refractive surgery, okay? If the IOL, there's a chance it can be decentered because of zonular problem or the capsular problem, okay? Or you're not happy with the angle kappa, angle lambda, use 0 spherical aberration, okay, lens. If the depth of the field is very important for the patient, okay? So the depth of field means that you want to have a bit of a defocus. Then again, you use an IOL with 0 spherical aberration. So if you are not negating the spherical aberrations, so whatever spherical aberrations in the cornea are there, but so there will be a bit of a defocus. So the quality will not be clear, but patient will be able to read a bit closer. So they will have a bit of an intermediate sort of a vision. But if the quality of the image is very good, okay? So patient don't mind wearing a bifocal or something like that. Then you have to use a negative spherical like thickness, which I prefer, okay? Then it will negate this positive spherical aberration of the cornea, and you will get a very sort of a good quality of the vision, okay? If the patient has a previous refractive surgery, okay, and this is important for certainly for hyperopic refractive surgery, because the use aspheric, because the patient has use positive spherical aberration IOL, okay? And if there is a patient is with a myopic refractive surgery, again, you can use the thickness, okay, or IQ. So this is important for hyperopia. Just remember that you have to use an IOL with positive spherical aberration so that they can cancel the negative spherical aberrations that has been created as a result of an oblate cornea. So again, this is, we touched it initially. So there is a pre-operative assessment where you get the simulated K readings. Here also an important thing you can get is about total corneal irregular astigmatism, okay? And this gives you spherical aberration. This is important for you to decide whether you can use a multifocal IOL or not. In general, less than 0.3 root mean square is taken as normal, between 3 to 5 is not good, and certainly you must not put a multifocal IOL if there is total corneal irregular astigmatism is more than 0.5. I think Zernike is too much, and it needs a sort of a whole another sort of a hour or so. If you want, we can discuss Zernike here, but I think that is too much of a talk. So let's stop here and we can have some discussion or some questions. Any questions? Anyone listening? No one listening and no questions?
Dr. Ahad, thank you for this lecture. This is Mohammad Al Khalifa. Dr. Ahad, you mentioned that in IOL calculation we should use the equivalent case, not the true power, true net power of the cornea. This is when is it that a must we use equivalent case when we are going to use IOL master, or even in online available calculators as well?
No. So basically, you should technically don't use equivalent case, okay? So don't use equivalent case, okay, at all. In a virgin eye, you don't need to use it, okay? And so Holiday, when they created equivalent K, okay, so they didn't have these ray tracing formulae at that time, and these are all the regression formulas which we now have, okay? Oslon, Cade, and stuff like that. So now we rely on these Barrett, okay? So these IOL calculations are far more accurate because they use more variables, okay? So now, if you have to use it, so you cannot use, so in a virgin eye, you can use SIM-K, okay? And this SIM-K is more or less the same as IOL master K, okay? So you cannot use sagittal or axial K, you have to use SIM-K. If the patient has got a corneal scar, okay, or patient has got a previous LASIK or keratoconus or RKs, and sometimes the cornea is so irregular, you cannot use the IOL master case at all. In that case, you have to use E case, these equivalent case, and you can put it in IOL master. You got my point?
Yes, clear. Thank you.
So Abdurrahman Anazi, thank you, doctor. How we can assess progression on keratoconus in 4 refractive map? Okay, so again, progression of the keratoconus, let's go to the 4, how do I go back?
Dr. Mohammed, in the meantime, we are trying to flip this. What did you say that about the don't use the K as of IOL master in cases of what?
So in a virgin eye, okay, you don't need to use any case, just use IOL master, okay? If the patient has got a myopia, okay, sorry, a LASIK treatment, then you're going to use Hazig-L, or you're going to use ACRS calculation, stuff like that. Again, in that case, don't use E case. I only see the E case, and if I have got a good peak, I tell them that I am quite comfortable that what I am planning, it will hit that target. But if I don't see any peak, then I tell the patient, so there's a chance your cornea is too irregular. My feeling is we may not be able to hit the target, and you may end up with more myopia or more hypermetry. This is where I don't use. So the only time I use it, so just to clarify, virgin eyes, don't use it. Post hyperopic or post laser myopic correction, don't use it, but just get an idea to see how accurate your post-op refraction will be. But if the cornea is highly aberrated, okay, and you cannot get a good case from IOL master, then you have to use this equivalent K readings and put it in the IOL master.
Okay.
So progression of the keratoconus, you look from the 4 maps and you look for anterior elevation, posterior elevation, K1, K2, and blah, blah, and the thickness. So again, so basically it talks about refraction, half a diopter change in the refraction, half a diopter change in the astigmatism, half a diopter change in K2 if it is increased, more than 0.75 diopter or maybe 1 diopter in Kmax. Kmax is not accurate because Kmax is usually peripheral, and certainly if you are using a sagittal or axial map, and if there is a slight misalignment, the Kmax will be increased. Okay, so that's why if you want to check for progression, you can use a tangential map, which is better, but again, it is too much of readings there. Anyhow, K2 increased by more than half diopter, Kmax increased more than 0.5 diopter, which means probably 1 diopter, and the thinning. So thinning is very variable because there is an epithelial thickness compensation over there as well. In general, they talk about between 2 to 3%. Okay, if it is more than 3%, certainly it is progression. So the patient has, let's suppose the patient has 496. Okay, sorry, 487 here. So 3% of 487 is almost 4.8 into 3 is 12, 13. So if it is more than 13 micron difference, so people take 15 micron as a standard. Okay, anything more than 15 micron is taken as progression. But again, you have to repeat it. And again, it depends on the percentage. Anything more than 2 to 3% is a progression. Any K2 increased by more than half diopter is progression. Any Kmax increased by more than 0.75 is progression. But again, you have to look at different things, okay, different times. Sometimes the epithelials have been thickened, okay? So it could be a false progression. It gives you a steeper K, okay? So you have to look at different things, but in general rule, more than half a diopter increase in K2, more than 15 micron or 12 to 15 micron decrease in the corneal thickness, more than half a diopter increase in astigmatism or refraction, and more than 0.75 diopter increase in the Kmax is taken as increase, and you can consider doing cross-linking. Posterior elevation, I mean, there are still data is coming about how accurate posterior elevation is, because technically it should be very accurate, okay? But again, people are not sure how much increase they will use it to call it is increased from 14 to 24 or 14 to 20, okay? So hopefully in the future, the posterior elevation sort of a data will be normalized.
Dr. Ahad, this is Mohammad Ahad again. You talked about the topometric indices for keratoconus. I saw some physicians, they're using their presentations, they have data about predicting the visual gain after some procedures that they will do, such as intrastromal rings. Are they that accurate now, or that's still, there are only few reports of that?
I think topometric is important. It doesn't say, it doesn't tell you how much improvement you will get. What it tells you in a way that how effective, okay? So it's an indirect way of saying, okay? So let me put you in another way, okay? If the cone is central, okay? If the Ks are 52 or 50, okay? If the corneal thickness is, let's say, 400, okay? I know that this patient will benefit more with rings compared to the patient who has got a cone which is peripheral, not even paracentral, whose Ks are 58 or 59 or 60 even, and whose central thickness is 350. So I know very well. So topometric data is basically quantifying how bad is the surface of the cornea, okay? How irregular is the cornea, okay? So it does not tell you that how much improvement you will get, but it tells you that this patient will benefit and this patient will not benefit. You got my point?
Okay, thanks.
Who wants to have a lecture on Zernike in the future? No one interested? Okay, question. How significant is the effect of dry eyes on pentacam perimeter? Very significant, very significant. Just today we did a pentacam on a patient who has got applanation tonometry done. That changed its parameters. So forget about dryness. So yeah, so if the surface is dry, you will just get an irregular corneal surface. Although compared to topography, where Myers are used, this is less sensitive, so you can still get it, okay? But I will still avoid using pentacam if the patient has got dry eyes, and certainly I will not use a premium IOL if I will base my decision based on the irregular astigmatism, because the first thing it will come, there will be higher order abrasions because the cornea will appear abraded, okay? It will show more irregular astigmatism. It will show. So best thing is to have a good lubricated cornea, and then you can decide whether you want to use a premium IOL or not. Okay, Yazid, inshallah, we'll see whether we can. Yeah, ideally, we used to run this course for 3 hours, and I had to run very fast, and I had to skip many slides here. So hopefully in the future, when it is physical and we have got a good whole 3 hours, then we will run it, and then we'll have the question and answers, and we will do the Zernike as well, and more about irregular astigmatism, inshallah. Great. If no questions, then we can have good
Assalamu
evening.
alaikum, Dr. Ahad.
Yes, sir.
This is late. I'm Dr. Raid.
Right, yeah, right. How are you?
Yeah, I got a question, Doctor. When do you prefer using the topography rather than the tomo? I mean the MS-39 for measuring the case. Is there any particular scenario where you depend on the topo rather than the tomo?
Okay, I use topography if I have to do a topography T-cut, okay?
Okay.
And this is the biggest mistake we do all the time in our ORs. We use tomographic data to do topographic guided treatments, okay? So tomography is more accurate, okay, because it is less sensitive to dryness and stuff like that, okay, and it gives you a better idea. So the only time I want to have a topographic data, which I'm afraid we don't have it in the clinic except MS-39, is when I'm planning to do a topo-guided custom ablation, okay? And then I will try my best to use the topolizer, not the oculizer. So topolizer does the topography and oculizer does the tomography. And I will use the topographer or the topolizer to do the T-cut. The problem is most of the time, so in virgin cornea, it works nicely. The problem is most of the time, the cornea is aberrated. So these are post-LKP, PKP patients, okay? So the cornea is too aberrated that the topography is not accurate. So as I said, that the tomography is less sensitive, okay? So you can still do tomography, okay? And then you can use T-cut, but actually it kills the purpose that you are using tomography to calculate topography, and then you are using it to calculate the algorithm. But that's the only time I will use topography, when I'm planning to do a T-cut.
So if you are going for a T-cut for like in a patient with the keratoplasty, you will use the, for example, the serous, the
Yes.
topography.
Yes, so I will use topography. Yeah.
Okay, thank you. Thank you so much, Dr. Ahad.
Do you think OpScan can offer any advantage open up? No, I think OpScan is sort of an obsolete now. So if any one of you remember, probably Dr. Ahmed Dail was here at that time. So yeah, we used to have OpScan in our lecture, but we're not using OpScan anymore. So it's obsolete basically. Yeah, sorry for the speed of the lecture, because this lecture was meant to be for 2.5 hours. Well, certainly 2 hours, and I squeezed it into 1 hour and 10 minutes. So great. If there is any question, great lecture, thank you. Okay, if there is no more questions, then thanks a lot for coming, and hopefully few of you have got few things which you have learned new today. Thanks a lot, and inshallah see you again.